Just down the river and across the Gulf.
Yes.
Okay, it's 8:05. Let's start the meeting. So, good morning, everybody. Welcome for International Trauma Grand Rounds. This year 13 of this meeting. Today, you're gonna have the honor to have our friends from Ahmed Hospital in Doha, Qatar, to present a case. The presenters are gonna be Dr. Sando Rizoli, Director, Medical Director Trauma, Ahmed Hospital in Doha. Also, Dr. Ruben Peralata, Consultant Senior Chief of Trauma, Surgical Trauma at the Ahmed Hospital in Doha, Qatar as well. And Dr. Ahmed Faidh Abdul Aziz, another Surgeon General at Ahmed Hospital in Doha, Qatar. We're gonna have like you all to participate, interact in this presentation. We're gonna be asking many of you to make some comments at some time during this presentation. Dr. Peralata and Dr. Rizoli, thank you very much for leading your team and to present once again in our meeting. Thank you.
Thank you, Antonio, and thank you, all of you guys, all friends, past friend, present friend, and future friends. Greetings from Doha, Qatar. Good morning, good afternoon, good evening, depending on the latitude of the world that you have. We're going to present a case by our second-year fellow, Dr. Faidh Ramzee, is our trauma and critical care fellow. He's from Bangladesh, trained in India, and is also Arab born in general surgery, and MRCS from London. He's been a great recruitment for our team, and you guys can enjoy our case that is titled chest pain post for 1 year later. I have to thank Dr. Rizoli and Dr. Verna, part of our team, because we treat most of the patients in a multidisciplinary fashion. Dr. Ramzee.
Thank you very much, Dr. Ruben. And I'd like to thank Dr. Rizoli and the Pan American Trauma Society for giving me this opportunity to present this case at the International Trauma Tele Grand Rounds. So we have no actual or potential conflicts of interest in relation to this presentation to declare. As we've already mentioned, we are coming to you from Doha, which is the capital of Qatar, which is a tiny country in the Middle East, population of just around 3 million. And our trauma center is a level 1 trauma center. It's the only only trauma center serving the whole population of Qatar, and it's the only trauma center internationally that's accredited by the Accreditation Council of Canada. Okay, so moving on with the case. So our story begins back in June of 2020. A young 36-year-old, previously healthy male who was operating a crane at a construction site, which toppled over and fell down almost 20 meters. And he was entrapped within the crane, and he was pinned down from the thorax downwards. There was a prolonged extrication time of about 50 minutes to get him out of the crane. However, when the EMS team arrived at the patient, he was awake and alert, GCS of 15. They noted that he had chest abrasions, a scalp laceration, and he was complaining of pain in his pelvis. He was transiently hypotensive, but responded to a liter of fluids given by the EMS team. Following this, he was immediately transported to our trauma center. In the trauma bay, before the patient arrived, we were notified this was a level 2 activation. And once the patient arrived, we noted that he was slightly tachycardic with a pulse of almost 120s and blood pressure hovering around 110/80. And he was slightly tachypneic as well. He was maintaining saturation just on a face mask. And on examination, there was unchanged as the EMS examination as well. So we proceeded according to the ATLS protocol, and we performed a chest and pelvic X-ray. The pelvic X-ray was normal. This was his chest X-ray. As you can see, there's some haziness on the left side, possibly effusion, lung contusion, and a couple of rib fractures can be seen. We then proceeded to do the blood works and proceeded with a CT scan. So his initial blood results were as follows. WBC was elevated, hemoglobin 12.4, and he was noted to have deranged renal functions. His creatinine levels were elevated. Troponin was within normal, and he was slightly acidotic, the lactate of 1.9 and myoglobin of 3,000. ECG at the time was unremarkable. This was his initial CT scan. This is a CT scan of the chest. As you can see, there's quite a significant collection on the left thoracic cavity, left hemithorax, the hemothorax, as well as rib fractures, as you can see by the arrows. The CT of the abdomen revealed that he had a grade 2 laceration or grade 2 injury to the spleen with an evidence of a blush, as well as it was a grade 3 injury to the spleen and a grade 2 injury to the right kidney as well as the liver. So this was the final report of the CT scan. It was a crushed chest. He had bilateral rib fractures, extensive rib fractures with a flailed chest segment on the left side, the small pneumomediastinum, the moderate left-sided hemothorax with lung contusion, and bilateral trace pneumothorax. The abdomen, as I mentioned, with the splenic, liver, and renal injuries. All right. So we have a patient who has sustained blunt abdominal injury, basically a crush injury to the chest and blunt abdominal trauma, multiple rib fractures, and splenic and liver injuries with evidence of a blush. He's slightly tachycardic, and his blood pressure is holding on for the moment. So at this point, I'd like to open up to the floor and get some input from the rest of the audience as to what we would do next. Just to make it more interactive, we will also be releasing a poll so that everyone can participate and we can have view the results at the end of the discussion.
Four questions.
Okay, at this point, I'd like to open up for any comments regarding what would you do next in this case.
Okay, let's start going around the room. Dr. Hoffman from Boston. So, what did you do in this situation, sir?
Well, the first thing I will do, this patient has a splenic injury with a blush. I saw only a few cuts, but this looked like a grade 4 to me, not a grade 3, because it appears that the hilum is involved. So the first thing is to go to, if the patient is metastable, I will try to embolize the spleen, embolization of the main splenic artery, and the spleen will be preserved through the short gastrics, and go from there. I don't have enough information to say if this patient will need anything done in the chest, probably a chest tube for most likely, but the ribs were very displaced, so might need replating, but that would be in the future. First step for this patient is embolization of the splenic artery and go from there.
Okay, thank you. Dr. Suparak from Thailand. Good morning. What did you do in this situation, Super?
Good morning, Dr. In this patient, I agree with putting in the left chest tube and put him in the ICU for observation of his breathing. And the other things are the injury in the abdomen. I agree with Dr. Hoshman that he may need embolization of the spleen. But because he's hemodynamically stable and has no peritoneal size, he's a good candidate for non-operative management of the abdominal injuries too. So the breathing, I would put in the chest tube and observe him in the ICU. If the respiration status got worse, he needs intubation. And for the injury in the abdomen, I would go with angioembolization of the spleen and observe in the ICU. Thank you.
Okay, thank you. Let's go, Dr. Untrak. Dr. Untrak in Baghdad. I don't know if you have angioembolization. So how would you treat this patient in this environment without a lot of research, sir?
Right. Well, today I'm in Florida, but in Baghdad, I agree with all the comments. So I would drain the chest, and then we were talking a couple of weeks ago about size of chest tubes. I just recertified the ATLS, and the American College of Surgeons no longer recommends the 36 to 42 French chest tubes, just 28 to 32. as long as it drains the chest. And that makes sense. I think there's good reasons for that. But so I would do that. And then in the States, I agree, angio after that, and then embolize the blush. They can, at the same time, they can do a drive-by angio of that right kidney, but that really just needs to be observed. And then depending on the amount of pain he has, you can ask the anesthetist to do a paraspinous block, easy, and then observe it. In Baghdad, if I don't know what his vital signs were after the liter of saline, but if there was any doubt, then we would take him to the OR, and at 36, if it were simple, to just do a splenography, fine. Otherwise, we would do a splenectomy before transfer, because he would fly depending on where he would go. If we would send him to Qatar or to Kuwait or Dubai, it's a couple hours away, and many of the patients wind up going to Landstuhl or elsewhere. But so we would have to be more aggressive and do less of the minimally invasive surgery, and before transfer, we would discuss with the receiving surgeon. But in the States, I agree with Dr. Hochman and Dr. Supa.
Thank you, Dr. Ontrak. Dr. Pereira from Svite, Brazil.
Thank you, Antonio. Nice to see everybody there. Sandro, Dr. Ruben, Dr. Aurelio. Nice to see you all. I do almost the same. Angioembolization for the spleen, left chest tube. I would just add that we have air in mediastinum. Perhaps I would add a bronchoscopy to see if there is eventual airway injury like trachea or the bronchus. And there's a bad flail chest there. I think probably there are a considerable deviation in the ribs. So I would ask if anybody here would eventually, for a second moment, consider to fix that ribs. That's it. Thank you.
Okay. Thank you, Parreira. Dr. Chioderis from Panama. Marta, do you have angioembolization available? Do you do rib fixation? Dr. Chioderis? Or maybe she's having some issues. So, meantime, Dr. Aurelio Rodriguez.
Yeah, good morning.
Please, good morning.
I in order 1, 2, 3, 4, 5. I put a chest tube first before think about embolization. Patient is theoretically stable, but with tachycardia. I want to express my thoughts about chest tubes. For 40 years, I taught hundreds now attending trauma. That chest tubes are there for drainage, not as an ornament. But the minimalistic group of the college, no, we can put a 32. Yeah, but I prefer to put a 36 or 38 or 40. That's the shock trauma. My generation, where we taught them to put big mamas. Chest tubes are there for drainage, no ornament, because they can clog. They can clot, and then you're wrong. Okay, a CAT scan shows, in addition to the hemothorax, the broken ribs. Be careful, by the way, broken ribs in the back broken ribs. They can perforate the aortas. I had a patient who perforated 3 weeks after it cut the aorta through and through the rib. The thing is, the aorta looks okay. I want you have to clarify two signs in CAT scan for the residents of ruptured aorta is the contour of the aorta is normal, and there is no aortic hematoma. That's the two things the radiologist, or you put no better than radiologist, how you may diagnose the ruptured aorta. Periaortic hematoma and contour are normal. This is normal. But I have the same question, like the doctor, my friend from Brazil. Where is coming the pneumomediastinum? Is the pneumothorax, or have to rule out 1 point, esophageal injury or bronchial injury? And don't forget that this patient has elevation of the hemoglobin. He has been compressed for a long time. That he has having a problem eventually about, the syndrome of compression and myoglobin, et cetera, et cetera.
Thank you, Dr. Rodriguez. Dr. Jose Pascual, presenting WST, your comments, sir. How would you manage the situation at your hospital, please?
Yeah, thank you, Antonio. Thanks for having me. So I'm going to take a different opinion to some of what has been said. I agree he needs a chest tube as soon as possible. I'm not sure. I was a proponent, as Aurelio said, always to put a 36 French, and we've had this debate back and forth at our shop. And really, if you look at the Colorado and the LA County data, one would think maybe it's not that important. And my concept that smaller tube clots may not be true. So we've actually started moving away from very large chest tubes for hemothoraces, definitely. My other worry is that there's 3 solid organs that are injured here. There's a kidney, there's the liver, and the spleen, all of which are high-ish grade. And so there's something emergent that needs to be done for the right kidney with a blush. But because there are 3 solid organs that are injured, my worry is that there's an accompanying hollow viscous injury. Some older data from the 80s suggested that if you have more than 1 solid organ injury, the concomitant hollow viscous injury risk rises as you have more and more solid organs injured. And if I remember correctly, 3 solid organs puts you up to 40% chance of a hollow viscous injury. So I would explore this patient to get control of that kidney and hopefully not take the kidney out, but control it and then go to embolization after the chest tube.
Thank you very much, Jose. And Dr. Meizoso from Ryder, any extra comment before you going to check the result of the pool?
Oh, I think I agree with most of the things the group has said so far. I would definitely proceed with the chest tube early on, and then I would probably angio this patient and see what they have going on.
Okay, thank you very much, Jonathan. Back to Qatar. So we are curious to see what was the result of the pool.
Thank you very much for all the comments. I'm not sure if you can see the results of the poll here. Oh, it's not showing. Yeah. Okay. There. I think you should be able to see it now. I guess we all agree that no one's going to send this patient home. That's for sure. But I think the general idea is that our approach would be depending on the setting that we're in and what resources we have. So I think the majority of the group opted for embolization plus ICU and also chest tube. There were just 2 who suggested that the patient goes to OR for splenectomy plus minus rib fixation. So this patient actually had had a blast from the spleen and not the kidney. So this is what we did. So we opted to insert a chest tube first. We inserted a size 28 French chest tube, and he brought out around 500 ml of blood. The patient remained relatively stable hemodynamically, so we then opted to proceed with interventional radiology guided splenic embolization. He did not have any further drop in hemoglobin, and he did not receive or did not require any blood transfusion. Following this, he was admitted to the trauma ICU for observation. During the course of his stay, as I mentioned before, he came with deranged renal functions, and this persisted over the course of the next few days. And he was worked up for this AKI, and eventually a workup showed that he had chronic IgA nephropathy, which was not known previously. Over the next few days, the patient persisted to have left-sided chest pain over the flail chest, and his chest tube output was quite significant. It was bringing out a good amount of serosanguinous fluid, although he did not have any respiratory compromise during this time. So we refer this patient to our rib fixation team. We have a dedicated team within our trauma team who looks after the chest and mainly deals with rib fixations. So we refer the patient to that team, and they requested a repeat CT chest with 3D reconstruction. And this is what it showed. As you can see, multiple rib fractures on the left side with a flail segment on the left with some displacement. So the options were discussed with the patient, and we offered the patient a rib fixation at the time, but he declined. And after a couple of days, he was discharged home. He had 2 follow-ups over the next 2 years in our clinic, and he was doing fine, had no complaints, and he had a follow-up chest X-ray on his first follow-up within 3 months, which was unremarkable. And he continued to follow up with the nephrology teams for his chronic kidney disease. So that's the end of the first episode of this case. So moving fast forward a year later, 1 year later, he presents to an outside hospital at 2 in the morning, comes with central truncal pain in the epigastric and the central chest over the past couple of hours. In the emergency department, his heart rate was in the 80s, his blood pressure was on the higher side, and his respiratory rate was slightly tachypneic. So the working diagnosis by the emergency team at this outside hospital was possibly acute cholecystitis versus gastritis. So he was being worked up for this. On examination, they found that he had central tenderness in the epigastric region, and his ECG at the time was unremarkable as well. His labs at the time showed a normal WBC count, hemoglobin of 12, and still persistent deranged renal functions. His cardiac markers were normal. He was slightly acidotic with a lactate of 1.4 and bicarbonate of 19. Then they proceeded at 5 a.m. So he came to the hospital at 2 a.m. and at 5 a.m. They did a chest X-ray, and this is what the X-ray showed. Yeah. Quite striking. See what appears to be gas bubbles within the left hemithorax, concerning for diaphragmatic hernia. So given these findings, they decided to proceed with a CT thorax and abdomen. So it took a while for them to proceed with the CT. So he arrived at 2 a.m. and he waited for almost 8 hours in the ED until his CT was to be done. So while waiting for the CT scan, there was a dramatic turn of events. He suddenly went into cardiac arrest. It was asystolic. CPR was commenced immediately and received 6 cycles of CPR, after which he had return of spontaneous circulation. He was intubated and ventilated, and then they proceeded to do the CT chest and abdomen. And this is what they found. You can see almost a
essential gastrothorax.
Yeah.
There was multiple small bowel and large bowel loops, all in the left side of the chest, pushing the heart, the mediastinum, to the right side. Basically, a tension viscerothorax. So once they found this, so this is what the final CT report showed: a left diaphragmatic hernia containing abdominal fat, transverse colon, descending colon, and jejunum, and there was features concerning for necrosed bowel, strangulated bowel. So the patient, from this point, was immediately, they contacted our trauma center at Ahmed General Hospital, and the patient was immediately transferred to our care for further management. When he arrived to us, he was tachycardic, heart rate of almost 114, and severely hypotensive and severely tachypneic as well. And he was on a high dose of noradrenaline. His ABG at the time showed a hemoglobin of 10.5, acidosis, lactate of 4.4, and bicarbonate of 13.5. Right. So here we have a patient who is 1 year after a crush injury to the chest, presents with severe chest pain and epigastric pain, and arrests in the emergency department in an outside hospital, has 12 minutes of downtime, and a CT scan down shows a tension viscerothorax. So now we'll move on to the next question. I would like to ask the group again, what would you do at this point in this patient who's come to us in extremis with a tension viscerothorax?
Okay, let's go to pool questions. Yeah. So Dr. Suparak from Thailand, from Bangkok. You first, sir. What do you do?
I think there's still some hope, and we should explore the patient. The approach for this patient should be exploratory laparotomy. And if we had performed laparotomy, like Dr. Pascal suggested, we wouldn't have had this problem at the first place. It's difficult, but I think we should give the patient a chance. Thank you.
Thank you. Dr. Parreira from Brazil, would you do any other further workup in the first admission? Would you do a thoracoscopy or laparoscopy to evaluate for the diaphragmatic injury? So how do anything else that is easy to tell afterwards, but how do you manage this? Would you do the refixation for sure? Or so please tell me a little bit more about your management of this situation. Complex case.
Well, I would like to congratulate the authors for bringing here this subject. Is really so difficult to look for diaphragmatic injury in blunt trauma patients. We know there are a little bit of them with rib fractures that develop diaphragmatic hernia afterwards. And I've just was looking at a paper that is from 2021, and the group was Azhar Hussain, the first author, and Hunt. They are this is published in the Journal of Chest Surgery 2021. And I've been through this paper, just curiously some days later and some days ago, and we had in our hospital a situation in which we operated the guy for the splenic injury and accidentally found the diaphragmatic injury, and we corrected, but it just lucky, yeah. And I'm not sure. I don't know if we have data for really establishing a protocol for investigating diaphragmatic injuries in people with rib fractures. In this patient, in this work here is more than 1,500 patients, only 14 had diaphragmatic injuries. So we're still looking for the best, perhaps select for best selecting the patient for this search. But about the case, I would operate the patient, certainly. Start with laparotomy, is not possible, open the chest.
Thank you, Dr. Parreira. And again, that's another objective of this meeting, or another goal, right? So you have like a question, so maybe you can create a multi-center protocol and then do some research together and try to publish some data. But on track, please tell me your thought about that.
Yeah, so when I saw the slide that said 10-hour, 15-hour wait, and then I thought it was your hospital, and I was perplexed. I said, oh, no, these guys are level 1 trauma center, you know better. And it wouldn't fly in the States. I'm sure it doesn't fly in Qatar also. So I think that hospital was probably not used to taking care of these patients. They need a little encouragement and just follow up. And I think they did the chest X-ray. They saw the opacification with the air bubbles, and probably if they couldn't do the CT right away, probably because they just prefer to wait till morning for these things. There was no tech there. Then they should have just transferred the patient right away, I think would be the most reasonable thing to do. I'm sure you've had multiple chest X-rays after the initial injury for the first couple of months, and the effusion was gone, the pneumothorax was gone, the contusion was gone, the ribs healed. I guess he didn't have a clinical flail, or he would have probably consented to the plating. And then there was no sign of a diaphragm. So I think there may have been a small defect or necrosis of the diaphragm with fibrosis that then ruptured and incarcerated. And then because of the delay, he had maybe a strangulation of some loops of bowel. But I agree with the others. I would take him immediately for a laparotomy to reduce the hernia, and then deal with whatever necrotic segments you have. Rinse out the chest really well, drain it again, repair the diaphragm, and I think you've got a small window of opportunity now rather than just wait. So I would get it done. As soon as you reduce the bowel and remove the necrotic segment, his acidosis will get better, his clinical condition will get better. But waiting, I think, won't work well in this case.
Thank you, Dr. Ontrack. Dr. Kioderis from Panama. She mentioned that her connection is working out. Marta, your comments, please.
Good morning, everybody. I do not understand why was the needed to do a CT scan after the chest X-ray. I think we delay care. We put the patient in risk, like in danger to die. And I think only with the X-ray, the second was necessary to take the patient to the OR. I would not wait 24 hours on a her arrest to take this patient to the OR right away. That's my 2 cents.
Thank you. Dr. Jose Pascual, Dr. Pascual, your comments, please.
Yeah, thank you. I would agree that he needs to go to the operating room ASAP. I agree that any delay, especially in his shock state, would be deleterious. So unfortunately, some of our hospitals cannot do this surgery, so it needs to be transferred out, so be it. I think that the original injury is important, though. We need to talk a little bit more about the fact that that's a crushed chest. It's not just that he had rib fractures and a coincidental diaphragmatic hernia. I think he had a crushed chest with 3 organs injured, and I was mentioning a hollow viscous injury, but also a diaphragm injury on the left, which probably occurred there, may have been discovered intraoperatively. But now going to the operating room and reducing the contents, hopefully closing that diaphragm primarily, which might be difficult and may need some mesh.
Thank you, Pascual. Dr. Mezoso, we have a protocol here at Ryder. So it's penetrating into the thoracoabdominal injury area. You wait 24 hours and do a laparoscopy to rule out diaphragmatic injury. But how do you manage this blunt trauma? Any other special consideration, Dr. Mezoso?
No, I don't have any additional comments other than what's already been said. I agree with, I think for penetrating trauma, it's pretty well established at this point to the left thoracoabdominal region that you'd want to do a diagnostic laparoscopy before they go home. But as far as I know, I don't think there's any protocolization or even evidence to support that for blunt trauma. But, this is a good case to, maybe support that kind of a question, particularly with a crushed chest, as Dr. Pascual mentioned.
Okay, thank you. Dr. Horacio?
I have seen this, and I would have done this a little bit different. I seen this. I don't think that we need to go and look for a ruptured diaphragm initially, because we will do too many unnecessary surgeries just looking for the ruptured diaphragm. I think if this guy would have undergone rib fixation, which in my opinion would be good, because he would, that chest was very displaced, and usually you have a reduced chest volume and they present a few months later with collapsed lung. A thoracoscopy would have made the diagnosis. Having said all of this, when the patient presented like this, I am very surprised that they managed to this with close chest compressions. Usually when you have a case like this, you need to do a thoracotomy and decompress the chest, because it's very difficult. The moment the patient gets intubated, it's more pressure inside the chest. It's very difficult to keep this patient alive. This was good luck at the referring hospital, but this patient, in my opinion, needed a thoracotomy immediately. And when he will get to my hospital, I will proceed directly to the thoracotomy, because you need to repair the diaphragm, reduce everything that's inside the chest. You might have many additions inside the chest that will be difficult to reduce, because this has been more than a year. So it will be additions of the bowel and the stomach to the lung that you need to take down from the chest. And it would not be a bowel injury by then, except that in this case, maybe it's necrotic because it waited for several hours in the ED. But you can probably do the resection of the bowel or whatever needs to be resected, or you can convert to a laparotomy then, but I would approach this through the chest. So a very different approach. Sorry, thank you.
Okay, last comments, Dr. Eli Rodriguez. Dr. Rodriguez, throughout your career, tell me how many cases like that you
It's
found?
interesting. It's interesting. It's like I'm doing psychoanalysis here, all the expressions of the opinions. Some of the colleagues seem to came a little bit late, so they didn't get the whole thing, my impression, or whatever they're saying. But this is for the residents, I'm going to say, comments for the residents, because despite I'm sure they are working, they are doing cases, and that's why you are here. But I pretend they are here. Number one, we teach them in experience that the chest X-ray, the original first place, is different diaphragmatic laceration or rupture to herniation. It's quite different, okay? Now, we tell them that the best thing initially to rule out diaphragmatic injury probably is the chest X-ray, the original, no herniation. A chest X-ray originally has to be pristine. The diaphragm has to be pristine. Any abnormality in diaphragm is either is fluid in the chest or is a ruptured diaphragm. Okay. Number two, the diaphragm is very hard to see for people who really do trauma surgery, particularly in blunt trauma, and laceration is difficult. You have to have a light in the head to see it. The attending doesn't want to have the light, want the resident to have the light, okay? You have to have a sponging sticks to spread the diaphragm, because the diaphragm is like a old man underwear, all crinkled like that. If you don't spread it out, you're going to miss the hole in the diaphragm. You have to spread it out and be sure there is no hole in the diaphragm. You're going to miss it. Number three, when you repair the diaphragm we usually use horizontal mattress, non-absorbable, and running suture, because the edges of the diaphragm, you don't do the running suture interlock, they are going to lipos out. Okay. Now, regarding somebody talk about, and that's very true, cases after 2 weeks of ruptured diaphragm, the diaphragm has the tendency to retract it. So when I entered the right chest one time, I said, there is no ruptured diaphragm here. It was the liver who I was seeing. There was no diaphragm. The diaphragm was already retracted. So it's very possible, like some doctors said, do you know what you have to use a mesh? If when you use a mesh, you have to do pericostal stitches, in the mesh to hold the mesh. That's very important. Now, I don't know. I don't know if doctors want to go to the belly directly. Of course, if I was not there, I never get old, etc., we do arguments. I say I should go belly first. I'm not sure about that. So I hopefully there's some residents got my information. I know you know everything, so maybe for the residents can learn something.
Thank you very much, Dr. Rodriguez. Back to Qatar. So let's see how you manage this situation.
Thank you very much. Just like to share the results of the poll. I think most of us would. Okay, the results of the poll were 97 votes for OR. Most of us want to try and save this patient. Before I proceed, I'd just like to emphasize that during the first admission, the patient had actually had 2 CT scans, which did not show any suspicion of diaphragmatic injury. Although we do know that the sensitivity and specificity of the CT scan for diaphragm injury is not that high. And additionally, we did offer the patient refixation, but he declined. So moving on with the case. So what we did was, as soon as we received the patient from the referring hospital, he was taken straight to OR without further imaging investigations. Immediately proceeded to OR, and we went belly first. We performed a midline laparotomy, and this is what we found: black colon, transverse colon was completely gangrenous. As the group suggested earlier, there were extensive adhesions of the bowel within the chest, and we could not release the bowel. So we did perform a thoracotomy, dialysis, and release the rest of the bowel. We found, in addition to the gangrenous colon, we found gangrenous jejunum as well, around 15 centimeter segment. Both of these segments were resected and left closed, and we repaired the diaphragm, and the abdomen was left open, and the patient was shifted to the trauma ICU for further resuscitation. In the TICU, on post-operative day 1, he was hemodynamically stable. He was not requiring any vasopressors. He was sedated, and his GCS was E1 and motor score of just 1. However, his pupils were equal and reactive bilaterally. That same day, on day 1, the ICU doctors noticed that the patient had gross twitching of the face and the right upper limb. What appeared to be sort of a myoclonus, a status myoclonus, continuous twitching. The patient was started on levetiracetam, to which he partially responded, and valproic acid was added later on. So once these findings were apparent, we consulted our neurotrauma group. So within our trauma team, we have a neurocritical care team, a resident team as well, who assesses all our neurotrauma cases. And the working diagnosis at the time was possibly hypoxic ischemic encephalopathy. So a CT head was done on the same day, which was unremarkable. And after a couple of days, we did an MRI, which confirmed an anoxic brain injury, mostly around the basal ganglia. He eventually went on to have an EEG, which confirmed that he had seizures, frontal epileptiform seizures on the left side. So moving on to the third and the last question. So we have this patient who had cardiac arrest, a downtime of 12 minutes, and he had a tension visceral thorax, and underwent surgery, found to have gangrenous bowel, and the next day he's having these neurological symptoms of seizures. So my next question would be, what would you tell the family regarding the prognosis of this patient? Yeah, so these are the options. I'd like, again, to bring in the team to discuss what you think.
Yeah,
so before,
thank you. Before going to the asking the opinion, so I have a question here in the chat from Dr. Mohammed Bawazir. He's asking, how did you repair the diaphragm?
Yeah, so it was repaired in horizontal mattress sutures with non-absorbable sutures. It was about a 10 centimeter defect. Yeah.
Okay, so didn't need any mesh, so what the primary repair?
No, there was no mesh required. There was no mesh.
Okay.
It was easily, easily approximated.
Well, let's keep rotating. Let's ask some other opinions here. Dr. Kyoderis from Panama. So how do you manage the situation? Any other comments regarding?
Well, I will say that to the family that the prognosis is very too early to say, but that I won't be expecting a full recovery on this patient, unfortunately. But we will keep on doing and giving all the medical care necessary to wait and see.
Thank you. Dr. Ontrack, your comments about the surgical management and your experience about this case.
Of course. So, yeah, in this case, 36 years old, the family's devastated, and unfortunately, I think they dropped the ball in the other hospital, and the he it was probably an acute rupture of the diaphragm and incarceration. I can't imagine that he had the hernia for the majority of a year and without any symptoms until a few days before he came in. I suppose that's possible, but and in this case, I would ask the neurologist first. I wouldn't make a judgment myself, but ask the neurologist. So he's got epilepsy and anoxic brain injury, so he wouldn't be normal, but you don't know how much recovery he would have. But I would certainly, see what the neurologist said. The other point is, when you repair the diaphragm, did you see evidence of a chronic diaphragmatic defect with scarring, or did it look like it was just an acute rupture? That's a question for you, Dr. Faidh.
It seemed like an acute rupture. So what we were thinking is this patient probably had a small defect, which eventually popped out, causing a sudden acute herniation of the bowel. Thank you.
Dr. Pascual has a question, then please answer the question to him, then he's gonna comment after, just following. So how much time after ROSC was a myoclonic status symptoms?
Yeah, so it started within 24 hours. So day one post-surgery. So within 24 hours of the cardiac arrest.
Okay, Dr. Pascual, your comments, please.
So I think refractory status epilepticus post anoxic brain injury, as was seen on the MRI, is very poor prognosis. The American Academy of Neurology, though, says to wait 72 hours before issuing a prognosis. So I would wait till that time. You said there was valproic acid and Keppra that was given. I would have added a third and a fourth agent, even propofol and even potentially phenobarbital as a way to stop the seizures. If these were in fact myoclonic seizures, not just generalized status epilepticus, that's even worse of a prognosis. So I think that, yes, you need to wait at least 72 hours for prognosis, but this is not something that has a good prognosis at all. The chances of a full recovery are very, very low. And I think there's data to support that, as opposed to other situations which may be more hit or miss. Thank you.
Thank you, Dr. Pascoal. Dr. Parreira from Brazil.
Same idea.
Okay, thank you. Dr. Hodgman.
I think Dr. Pascual summarized everything perfect. I have nothing to add to that explanation. Thank you.
Thank you. Dr. Superek.
I agree with Martha that this is too early to say anything, and I'm not a neuro specialist, so I cannot say that he will never recover. The other thing to add for this patient is I think therapeutic hypothermia should be considered. If intraoperatively you could achieve good hemostasis and no worry about bleeding, I think he is a candidate to undergo therapeutic hypothermia for 24 hours. Thank you.
Thank you. Dr. Mezoso.
I think Dr. Pascual made a great summary. I agree with Dr. Hodgman. I don't have anything to add to that.
Thank you. Dr. Rodriguez.
Yeah, I have a question, three things. Number one, I agree with my colleague there. I don't understand how this patient has so many, this didn't herniated and necrotic in one day. This guy has been suffering with pain. How possible nobody saw him? He didn't, nobody pay attention. I don't understand. Hopefully, I guess you don't have legality like the United States or in Qatar, unless it's the Qatari family. But I think, I don't know, something wrong here. And number two, the fact of the, this is very interesting, how the culture is, When I worked to Sinai Hospital, it's not easy to sell, well, 30%, 40%, the red hippocampus. No, they want you to do more and more and more until the patient is dead. So in this case, I don't know what is your here work in Qatar. Maybe they have different way of taking the news, And American, many people say, okay, doctor, doctor, but tell me, how is it Qatar? Maybe you can explain it. It's easy to drop bad news to families, so how they take it, it's interesting. I never going to be working in Qatar, I'm too old to work. You have an answer?
Yeah, I can respond to you. Regarding your first question, so the patient was followed up twice over a year in our clinic. Actually, his last follow-up was about 2 months before he presented with his symptoms. And during those 2 follow-ups, he didn't have any symptoms. He was completely asymptomatic. He was doing fine. And he even had a follow-up chest X-ray on his first follow-up, which was unremarkable. And coming to the second question, I guess it's quite similar here. It's not easy breaking bad news, and most of the time, families want us to do the maximum possible we can to save their family members.
Thank you very much. You're in the final 10 minutes of the meeting, so back to Qatar. Let's see the result of the poll.
Okay, so I think we can see the poll. Most of us agree that it's too. You can see? No, don't see it. Yes. Okay, so this is the poll. I think most of us agree that it's too early to say. I guess this is a dilemma again when it comes to such a patient who's cardiac arrest, possibility of anoxic brain injury. When do we draw the line? When do we withdraw care? So it's difficult to say. So let's proceed and see what we did with this patient and how he progressed.
I have some questions. Just a question. I have some questions for Dr. Mohamed Bazawi. Any once bisecular phase, any role for neurostimulants such as amantadine? Any comment on that?
Yeah. So yes, I'm coming to that. Actually, I will talk about his progress over a very short period of time before we even considered the amantadine. So by the third post-op day, he actually started waking up. His motor function started improving, eye opening. He had spontaneous eye opening. His seizures were somewhat controlled with the medication that we mentioned previously. And by day 4, we took him back for relook, the second relook laparotomy, and we anastomosed the small bowel, performed the ankyloscopy, and closed the abdomen. However, given his background of chronic kidney disease, this hit led him to develop acute on chronic renal failure, for which he was hemodialysis dependent. He stayed with us for almost 2 months, and he was on anti-seizure medications. But remarkably, he made a full neurological recovery, and he walked out to the hospital, the GCS of 15, with just some slight weakness for which he needed a walking frame. Apart from that, he was doing well. He was on anti-seizure medications and was on regular follow-up with neurology as well as nephrology. So coming back to, I think that's the summary of my case. We had.
Okay,
Yes, I think Dr. Rizoli would like to make a comment now.
Yeah. So again, I was impressed, like how.
We cannot hear you, Dr. Rizoli.
We miss your microphone. We lost you.
You hear me now?
Yeah.
Okay, sorry. So again, I had forgotten what a pleasure it is to discuss cases with colleagues of this caliber, right? So it's excellent comments. I loved it. I think that our goal with this case was that we initially, when we saw this patient having what we thought was myoclonus, it was hopeless. We said, look, that's it. He's fried, right? It was 12 minutes down. They missed a dead colon inside his chest, and it's over. But it's true. Like don't give up too early, right? So this patient, day 2, was start to wake up. So despite the findings on the MRI, despite all of a sudden we realized it was not myoclonus, but was in fact seizures that he was having, and it was not easy to treat his seizures. He stayed in the hospital for 2 months. He had multiple septic complications and so on, but he walked home. So I think the message here is, and I think that's what we're hearing from many organizations and so on, is that we can't say it's over until it's over, right? So don't go too early. So this guy had a blunt trauma, had a cardiac arrest, survived it, and then developed what appeared to be significant neurological damage, and still he walked home. So I think that this is the core message for this case. Thank you very much.
Thank you, Doctor. There's another question. Again, we are going to another continent here. Dr. Yoshiro Kobe from Japan, he's asking, when did you connect the bowels and close the abdomen?
Also the number 3.
When or why?
When?
When?
When? It was on post-operative day 4. Day 4. So we did a small bowel anastomosis and a colostomy for the colon.
Okay, thank you very much. So your last minutes of the meeting. So you have the CME codes on the chat. Please go there. I'm gonna go around just final comments, and I'm gonna ask Dr. Hotman today to do the final, be the last one to summarize the lessons and the teaching points for everybody, for the residents here. So let's start, Dr. Ontrack, your comments, please.
Yeah, so when I saw the last slide, I said I thought that couldn't be so. That maybe I was dreaming. It was very surreal, but better to be lucky than good. The other hospital, they were lucky that they got return of spontaneous circulation and they didn't do the hypothermia then, but they were also lucky that they sent the patient to you and you did everything. And as Dr. Rizoli said, don't make the outcome a self-fulfilling prophecy. So, they're extremely well done, really, and it's a very satisfying conclusion to a case where he's up in a crane, fell down, then the diaphragm hernia, gangrene, survived that, and then the seizures, and he walks out of the hospital fully intact. That was just incredible. One question for you: in this case where you had 2 lengths of necrotic bowel, if the defect of the diaphragm were larger, would putting mesh have been an option here? I would in this case, regardless of how bad the defect was, but just interested in your opinion about that.
I guess if it was a large defect, we would consider using a biological mesh, but in this case, the defect was not too large, and we were able to easily approximate the 2 ends of the diaphragm. But yes, definitely we would consider that in an indicated case.
Okay, biological, but not polypropylene or.
Biological, yeah. So yes, in a contaminated patient with gangrenous bowel, dirty bowel, I would probably opt for a biological mesh.
Thank you. Dr. Suparak, what do you teach your residents and this young kid that's with you when he becomes a surgeon in a few years? What do you teach about this case to them?
To never give up. And miracle happens when you do your best. Thank you very much for presenting this case, and I learned a lot from you guys. Thank you.
Thank you. Dr. Aurelio Rodriguez, your comments, please.
Yeah, I have to remind the residents that Dr. Rizoli said the patient is dead when he's dead. Okay, I have been people who was 5-10 minutes with people fixed dilated, and I opened the chest and they went to college after that. So it's the age. Remember, age. I'm going to be 80. I will not be able to survive this. And 80 years old, he's going to die. But you have a young guy. You have to do every possible thing beyond, because you never know the reaction, The books, the index and numbers and many things, but I think many numbers are totally wrong. So, as Rizoli said, he's dead. When he's dead, that's what it is. This guy was not going to be. It was a young guy.
Thank you, Dr. Rodriguez. Dr. Parreira, your comments, please.
Just great case. Thank you for that. It was really a lot of education information here. I would summarize it. First, don't forget the possibility of a diaphragmatic injury in flail chest, especially if you had low rib fractures. And perhaps we have to find which patient would be a candidate for searching. Yeah, perhaps a thoracoscopy or anything else. The second thing was the second part, which was actually more impressive than the first one. So you taught us and remember us that you should not give up so easily. Thank you for that.
Thank you. Dr. Kioderis from Panama.
I just want to make emphasis that there is no need for a CT when you have this chest X-ray showing and with a previous history of trauma that is a diaphragmatic rupture, hernia, whatever you want to call it, and that's an emergency and needs to be like transfer. If you cannot fix it, transfer as soon as possible. The other thing that I want to thank all the Qatar team for presenting this case, that it was really, really interested. And thank you very much.
Thank you. Dr. Pascual from WC.
Yeah, I think Sandro's comments are very, very apt. Sandro, nice to see you. I haven't seen you in years, but I agree with you. Again and again, we discover that what we thought was non-survivable becomes survivable. And as Dr. Rodriguez says, the young age is a big variable there making this guy survive. Very nice case. Thank you.
Thank you very much. Dr. Marcelo Ribeiro, any generic comment here, please? Ribeiro from Abu Dhabi.
No, first of all, thank you very much. I was kind of stuck in here. I'm on call today, but I couldn't see all the case, but nothing different than I could expect. I have been visiting Dr. Rizoli and Dr. Peralata recently there, and they have an amazing service in Qatar. And yeah, excellent case, very good outcome. So that's we all talk that is not over until it's over. So that's another very nice example that we need to keep trying. And this guy was lucky enough to find a bunch of people trying to save his life, although he was doing a lot to not survive. So congratulations to the team, and glad to see everybody here in this meeting. Thank you very much.
Thank you. Dr. Hodgman, you are the professor that are gonna do the summary of the case today. Please.
This is the bad part. You let the smart people talk before me, so I don't have too much to add. Great case. I think that I don't think that you could have diagnosed this early. That's the only thing I will add. You have patient follow-up. You didn't see anything. 10 centimeters laceration after a year is a very small laceration. So it was probably, it's no way to make the diagnosis before unless you explore. And that's the reason they strangulated, because it's too small. So he coughed, something happened that day, herniated, that's the reason having the pain, because it's strangulating, and there was a delay there. But I don't think that you could have prevented it from happening. The incidence of diaphragmatic rupture is very low. In blunt trauma. When it happens, it's very difficult to make the diagnosis. We still have to try to make the diagnosis, but you can. And so I think it was a very, very interesting case. I was having some pictures I was just trying to upload to the chat, but I couldn't, of cases of mine where you can see this significant mediastinal deviation, which essentially is like a tension pneumothorax and should be treated as such. He didn't go to a trauma center the first time, but the cardiac arrest in a trauma patient usually, in a case like this, requires an emergency department resuscitated thoracotomy because it's really much faster than doing a laparotomy. After that, he stabilized and underwent a laparotomy, very successful. Congratulations. In terms of repair of the diaphragm, I have seen everything from non-absorbable mattress, horizontal mattress sutures with pledgets to continuous suture with PDS. All seems to work. The diaphragm is very forgiving. So the diaphragm might be have limited mobility after that, but usually you can bring the edges together. But that's what I have to add. And because the smart people spoke before me. Thank you.
Thank you very much, Dr. Hodgman. I would like to say, I like to please ask everybody to go to the chat and claim your CMEs. Dr. Rodriguez, do now, then let's talk in a few minutes about your CMEs, okay? I would like to ask Dr. Sando Rizoli to end this meeting. Dr. Sando Rizoli is also the editor of the Pan American Journal of Trauma, Critical Care Surgery, and was released today. He just released the new journal. And Dr. Sando Rizoli, please talk to everybody about the journal, please, and please end this meeting. And thank you everybody for joining us. We're going to have an announcement in a few days about this meeting. Please be ready for great news. And Dr. Rizoli, please finish this meeting. Thank you very much. A great case from Qatar.
So tomatoes and you okay? Can you hear me?
Yes.
Okay. So again, Dr. Martos, thank you very much. I have again so many names here in this list today that I admire. I had the pleasure to know, and I have the pleasure to be here today with. It's great to see you all. Thank you for this opportunity. And again, just making a little advertisement, the Pan American Journal of Trauma just came out, the newest issue yesterday. You're all welcome to come to the website. All our publications are available there at no cost, and it would be great if you consider submitting your next work to the Pan Am Journal. It would be a privilege for us. So thank you very much, Dr. Ramzee, for the excellent presentation. My colleagues here in Qatar, and Dr. Martos and colleagues, thank you very much for this privilege to be here today.
Thank you, Sandro. Thank you all. See you all next week with another case. Remember, next week the case is going to be at 12 noon Eastern time. Thank you.
Thank you. Have a great day. All right. Yes, please.
Dr. Pascual, you can talk in a few.